All right. Good afternoon, everyone, and welcome to the Henry Schein Dental Academy webinar series. My name is Adam, marketing specialist, and I'll be your moderator. This is part 4 of our 6-part webinar series focusing on treating patients with disabilities. If you happen to miss parts 1, 2, or 3 of this series and you would like to watch them, please email webinars@henryschein.com and we will be more than happy to send the recordings your way. We are excited to welcome back Dr. Maureen Perry as our speaker tonight, as she will discuss dental considerations for patients with epilepsy and seizures. Dr. Perry is the professor of special care dentistry and the director of the Center of Advanced Oral Health at the Arizona School of Dentistry. In addition, Dr. Perry is a fellow of the Academy of Dentistry for Persons with Disabilities and is a diplomat of the American Board of Special Care Dentistry. Before we get started, we have a few reminders. At any point during tonight's webinar, we do encourage your participation through the chat and Q&A features. Please type any questions you might have into the Q&A section of your control panel, and we will answer them live at the end of the presentation. Directly following today's webinar, we're asking that you complete a quick survey to let us know what you thought of the presentation. If you elected to receive CE credit for this webinar, it is required that you complete this survey in order to get your CE certificate. It's also required that you attend this webinar for the entire duration. Your CE certificate will then be emailed to the email address provided during registration, and your account will be billed the $20. Henry Schein is only able to offer CE credits to doctors licensed and practicing in the United States. If you have questions about the CE for this webinar, please email us at webinars@henryschein.com. All right, Dr. Perry, I will hand it over to you.
Okay, thank you so much, Adam. And welcome back, everybody. And welcome if you haven't been here for some of the other webinars in this series. Today, we're going to talk about patients with epilepsy and seizures. So this is just for your CE, letting you know it's certified. Here is my disclosure for your reading pleasure. Oops. And there we go. Learning objectives. So we're going to talk about the types of seizures. We're going to talk about the treatment of seizures. We're going to talk about dental adaptations for treating patients with seizures. And we're going to talk about what to do if a patient has a seizure while you're treating them. So what is a seizure? It's basically electricity in your brain gone wrong, right? So it's excessive electrical discharges from your neurons. A clinical seizure is one where you actually see the patient seize, and I'll show you some video of different kinds of seizures. And you might also have patients who have electrographic seizures, in that you only see, the only evidence you would see is if the patient was actually attached to an EEG. What is epilepsy? So it's recurrent seizures. So you have to have at least 2 seizures that are unprovoked by a systemic insult. So if you have 1 seizure, you don't have epilepsy. If you have 2 seizures and it's not it's an unprovoked seizure, then we know that you will then be classified as epilepsy. It comes from the word epilambinine, which is to be seized. It's a Greek word, and seizures that are provoked by systemic insult, such as metabolic imbalance, like a brain tumor or a stroke, are not considered to be epilepsy. So here's the seizure classification, and we have partial seizures where only part of the cortex is disrupted, and you just see and only one part of the brain is actually seizing. We have generalized, where all of the cortex is disrupted, and in the generalized, we see lots of different kinds of seizures, and we're going to talk about those. So let's look at a video of what we call absent seizures. So it's hard to recognize some seizures. So this is one of the things that you should pay very close attention, and we'll talk about it after we watch this brief video.
Hi, so today I'm going to try and catch one of my seizures on camera. So today I'm going to see if I can show to you on camera what it's like to have absences. He went online, he done all the booking.com, and went on booking.com. Really good. and it came with breakfast and he picked the superior room, which was so he booked it and I didn't really check. So I looked after, and it wasn't, I looked after changing it because the toilet in that one wasn't working. So yeah, so she my brain doesn't want to cooperate today, does it?
So in that video, you can see that the young lady is sort of pausing and she looks away. And you may also see that she has some fidgeting with her lips. She's licking her lips. She's kind of closing her mouth, opening her mouth, licking her lips, looking up, looking down, and looks like she's not really focused. And so that's what an absence seizure looks like. So it's important to recognize those. Sometimes we're not really sure what's going on with a patient. And here we're going to see some more of what we think of like a classic seizure with tonic-clonic seizures.
I tried. You just didn't study. Yeah, but no, I wasn't. I was doing video games. You were playing video games. Hun? Okay, all right. Okay. Hun, it's okay. Excuse me, ma'am. Can you please pass me my sweater and my bag over there? It's okay.
Sure,
okay.
What happened?
It's okay. He has epilepsy.
Should I call 911?
No. Hun, it's okay. It's not an emergency. Hun, it's okay.
Is he going to swallow his tongue? Are you supposed to put a spoon in his mouth or something?
Honestly, if we put anything in his mouth right now, he's gonna either choke or he's gonna break his teeth on it. The best thing we can do is just wait it out. We just gotta make sure he's safe and there's nothing around him where he can harm himself. It's okay. It's okay. On your side. Okay. Just breathe. I'm here.
So a few really important things about that video. So it's a complete myth that you should put anything in someone's mouth, right? Or they're going to swallow their tongue. That's not possible. Patients might bite themselves, or a person might bite themselves, and that happens sometimes during a seizure. The important thing to do is make the person comfortable, and we're going to show it in a dental setting in a little while. But you may be out and about. Here they are in a park, or you may be at a basketball game with your children or somewhere else, and somebody might have a seizure. And these are important things to remember. And we will go over them, but I wanted to really show you at the beginning that a seizure is not necessarily a medical emergency, in the sense that we have to call 911. We do have to address it. We do have to make the patient comfortable. We should turn them on the side. We should take anything that's in their mouth and take it out of their mouth to clear their airway. And you should time the seizure, and that's really important, because if it goes on for more than 5 minutes, or they seize again before they're actually awake and aware of what's going on again, then you may need to call 911. So let's talk about the epidemiology of epilepsy. So epilepsy, there's no racial or social boundaries. There's no gender predilection. Most of the time we see it in kids. We also might see it in adolescents, and we see it in old age. Up to 5% of the world's population might have a single seizure. We often see seizures in babies. We see febrile seizures in infants, and we see seizures in older people, and people who have dementia, and people over 80. It's pretty rare for working age people to just have a seizure. And again, if somebody doesn't have a history of epilepsy and has a seizure, especially a working age person, then that is a medical emergency, because that's not being caused by epilepsy, and we need to find out what is happening with that person. So again, not unusual in infancy or old age. At other times, working age adults, you should not see a primary seizure in a working age adult. You shouldn't consider that epilepsy. That is definitely a medical emergency. Status epilepticus. So you saw the lady timing the seizure, and the reason we time it is because you don't want the patient to go into status epilepticus. If the seizure is more than 5 minutes, or the seizures are close together and the person isn't recovering, in other words, they're not totally conscious and aware of their surroundings, then you should call 911. There's different kinds. Patients have convulsive and non-convulsive status epilepticus. So when patients are convulsing, you have to have emergency treatment, and the patient's going to have to be at the hospital. The patient's going to need medications to break that seizure. So again, it's important to time the seizure once it starts. How many people have seizure? Well, the total number of existing cases, and that means prevalence, right, is the number of people who actively have it in the United States. And that's about 2.7 million. About 326,000 are school-age kids, and about 570,000 are older people. The incidence is the number of new cases, right? So about 300,000 people in the US have a first seizure each year. 200,000 new cases of epilepsy are diagnosed, and most of them, again, as I said, older adults and kids under 2. What is the risk? Well, there's certain populations who have a higher risk. So we see children with intellectual disability, we see children with cerebral palsy, children, if they have both CP and ID, they're 50% more likely to have seizure disorder. So we often see that as a triad together in the special care population, where we see CP, ID, and seizures. Very common. Adults with Alzheimer's is much more common, and patients who've already had a stroke, it's common. So what kind of treatments do these folks get? There's a variety of treatments from a medical perspective. Vagus nerve stimulation, ketogenic diet. I used to have to explain what that is. Now I don't really, because it's like all the rage, but this is a very specialized one. Surgery, surgical interventions, and there, of course, are pharmaceutical interventions. So when do people have surgery? When patients have breakthrough seizures. So about 1 in 3 people with epilepsy have drug-resistant epilepsy. So, you're talking about like 1 million people in the United States. And if you're on 2 medications for epilepsy, that you only have a 5% chance that adding more medication will make you seizure free. So for people who have breakthrough seizures, in other words, they're on medication for their seizures, but they're still having seizures, so they're refractory and drug resistant, then they may consider what we call a VNS, which is a vagus nerve stimulator. So this is it doesn't go into your brain, okay? It's a pretty simple procedure. It goes under the skin, and they actually wrap the electrodes around the vagus nerve, okay? And the patient has a magnet. So you have to carry the magnet with you. It always has to be with you because you can't do anything. The VNS doesn't work without it. And when you feel like you might be having a seizure, you move the magnet over the generator for less than 2 seconds. So in other words, the patient swipes the magnet over it and it stops the seizure activity. So these, again, in the population that I treat at the center, we have many, many patients with VNS. Unfortunately, many of the patients also fail on VNS, and I don't have any great data on how many patients fail. I can just tell you that anecdotally, over the last 30 years, I've seen many patients who have a VNS and still have seizures, although they do not have as many seizures as they had before VNS implantation. So it has some positive effects, but it doesn't always stop all of the seizures. Ketogenic diet. So this is not like the keto diet that is all the rage today. This is really, really specialized. It is prescribed by a physician. They mostly use this in children. It's monitored by a dietitian. When kids don't respond to medications, rather than putting in a VNS, they'll usually try this first. It's extremely strict. It's much stricter than modified Atkins. And you actually have to write everything down or use an app. And it really, you have to measure everything that the child eats: calories, fluids, proteins, everything's weighed and measured. They don't use this so much in adults, and I think it's probably because there's like zero compliance. For children who are not independent eaters, in other words, they don't have access to food unless their mom or dad or another adult gets it for them, this can work. But again, it's very, very strict, and it really, you have to weigh in every single thing and write everything down. So it's pretty time consuming, and it's pretty challenging. Surgery, there's lots of different kinds of surgery, and I have them listed here. They're all kind of complex brain surgeries, and including, putting in other kinds of stimulators. But that is only considered for patients who are totally refractory with medications. I have several patients that have had different kinds of surgeries, and that's really for patients who are having, maybe 20, 30 seizures a day and really cannot function in any way. So then the last resort is to have this sort of neurosurgery. Lots of drugs are used for epilepsy. So here's a list here. And I think some of the more common ones are valproate, Depakote, and Depakine. We see lots of that. We don't see as much Dilantin, but we certainly still see it. I see a lot more of lamotrigine and some GABA drugs these days. They have a lot of side effects. I think the biggest one that we're always worried about is gingival hyperplasia, and we're going to talk about that pretty extensively. You see it in somewhere between 25 and 50% of patients on phenytoin, on Dilantin. These drugs are pretty hepatotoxic, so phenobarb, Dilantin, and valproate, so Depakote, Depakine, are really hepatotoxic. So these patients have to have liver function tests drawn monthly. And they really have to be watched because, again, the hepatotoxicity is pretty severe. All of the sedation meds, the seizure meds cause sedation. So sometimes we see patients on seizure meds and you're like, but the patient doesn't have seizures. And so some of our folks with intellectual disability, they may be using them to calm the patient down. So again, they may be using them off-label because the common side effect is sedation. We also see patients with rashes and stomach upset, headache. It can cause blood dyscrasias and it can cause teratogenic effects. So these drugs are, not They're great for stopping seizures, but they have a lot of bad side effects. Long-term medication, of course, we see with high sugar content and the liquid medications, particularly in kids. So Depakote actually comes in like a sprinkles. You can sprinkle it on food and it's got tons and tons of sugar on it. The liquid Depakote and Depakine has tons of sugar in it. So those aren't so great, but we see a lot of dental devastation from them. And there's reduced salivary flow in this population, particularly if they're also on psychotropic meds. Like many of our patients who have intellectual and developmental disabilities, they may have psychotropic drugs besides the anti-seizure meds. So patients with tonic, clonic, and atonic seizures, we worry about dental trauma, right? So patients have a seizure, they can't get to a chair. Patients have seizures and fall out of their wheelchair. Patients are walking and have a seizure and fall, and we see all sorts of anterior dental trauma as a result. So we see lots of avulsions, we see lots of subluxation, we see lots of fractured anterior incisors. And we also see soft tissue trauma. So if you're seeing patients with cerebral palsy or seizures, you have to be prepared for this because it could happen and they may come to your office seeking care. When you first meet the patient, you need to do a thorough medical history review. You really have to get a good seizure history. What kind of seizures do you have? What happens when you have a seizure? How long do they last? What is your typical first aid for your seizures? If you have a seizure at home, what do people do for you? Do you have known triggers? We have patients who loud sounds will trigger it. We have a patient who, if a car backfires in the parking lot, she has a seizure. Flashing lights, so any kind of strobe lights or things like that will certainly can cause seizures. If people are tired or they're stressed, if they're ill, they can certainly have seizures. So for patients, do you have known triggers? Have you had seizures because of lights or when you're tired? How often do you have them? Okay. When was the last time you had one? When's your most recent seizures? Have you ever been hospitalized for a seizure? And what kind of treatment are you receiving? So you want to know, is the patient on medications? Are they on several medications? You want to know if they've had a history of breakthrough seizures, if they have a VNS, if they've had any neurosurgery. These are really, really important. And they're going to really help you determine what kind of dental care is appropriate. So if you have a patient, let's say, who says, well, I have a history of epilepsy, but I haven't had a seizure in 4 years, and I take my medications, and I've never had a breakthrough seizure. Well, your treatment planning is going to be pretty much like everyone else, right? You're not really concerned that the patient's going to fracture anterior crowns. You're not so concerned that the patient is going to break a denture or a partial, right? Or it's going to cut their mouth when they fall. So that's different from someone who says, well, gee, I have seizures just about every day. And when I have them, I have to, if I can't find a place to sit down before the seizure comes on, then I've fallen and gotten hurt. And you want to ask that too. So have you fallen and injured yourself during a seizure? Many patients will have an aura before their seizure. They will know it's happening. So I always ask patients, like, do you have an aura? Will you be able to tell me if you're having one? And many patients do. Many adult patients, they've been trained to recognize that, and they'll be able to go and sit down, or they'll be able to tell someone who's with them, I'm going to have a seizure. And you saw in the video that the young lady realized that her boyfriend was having a seizure and immediately went behind him. And you should stand with your legs, one leg in front of the other, sort of spread out, and holding the patient. You want to get them under their arms, slide them onto you and down your leg so that the patient can lay on the floor. So ask patients, like, what's happened before? Get a really good history. If you have a patient who is a minor or has an intellectual disability, then of course you're going to need to get this information from a parent or a guardian. You're going to really want to know this. So dental considerations, again, we talked about gingival hyperplasia, and we're going to talk about the treatment of that. Certainly Tegretol causes aristomia and all sorts of stomatitis. And Depakine and Depakote can actually cause bone marrow suppression. So for patients on that, if you're going to consider doing large surgeries, you may want to get a CBC and with a diff, and you may want to look at if they've got any bone marrow suppression, because you want to know about their wound healing. You want to know how how their platelets are going to function. You should ask the patient if they have any history of bone marrow suppression or any delayed healing from surgeries as a result of being on valproate. So what can precipitate seizures in the dental office? So even patients that are compliant can have breakthrough seizures. And the most spectacular seizure I ever saw was a patient the very first day that I was in clinic at AT Still at the Arizona School of Dentistry and Oral Health. We had a young man. He came in with he had some intellectual disability, and he also had seizures, but he was an extremely high functioning fellow. He also had some serious mental illness. And he came in with another young man who he said was his caseworker. And he sat down in the chair, and we got his whole history, and he told me all about his seizures. And while he was giving me the history, he had a spectacular seizure where we could not even get the man off the chair. He literally seized right out of the dental chair. We got him on the floor. We protected him. We timed the seizure. The seizure went on for 5 minutes. We called 911. We had him transported to the local hospital. And we later found out that this person had some substance use disorder as well. We found out that he wasn't taking his seizure medications. And we also found out that the person who said was his caseworker was not actually his caseworker, but was a friend, and they were doing their drugs together. So the substance use disorder really complicated things. The patient ended up being in the hospital and then actually subsequently going to rehab. So street drugs are a real problem for patients who are self-medicating because they're trying to cope with having their seizure disorder and the disruption in their lives. These are, again, what triggers them? Fatigue, being hungry, right? Decreased insulin, hypoglycemia, stress, pain. If the patient faints, they might have a seizure, right? Interestingly, intravascular injection of local anesthetic can induce seizures. So it's particularly important to make sure that you are not in a vessel, right? And to aspirate when you're giving local, or you could actually precipitate a seizure. I will tell you that we had a patient that who did not have any teeth, and we were actually, they were doing some soft tissue surgery on the patient, getting him ready for his denture. They were going to do vestibuloplasty, and the patient came into the clinic, and all they did was give the patient a little bit of local anesthetic, and the patient fainted. They told me the patient fainted. So the patient recovered, and the patient was about 80, and they let the patient go home. And the next time I said, schedule a patient when I'm here. I want to see what's going on, because this is really strange. So I went into the operatory. I was there with the periodontist. He's been a periodontist for a great many years. He's actually done the surgery on me. I have great confidence in his abilities. And I'm in there with him and the resident. He injects the patient, and this wasn't even a block. He literally gave the patient an infiltration, and the patient had a seizure. And I knew it was a seizure because I looked at the way that the patient behaved, and while he had syncope, he was completely post-ictal after the event. And by that, I mean, he completely lost consciousness. And when he awoke, he had no idea where he was, who he was. He was drooling excessively, and he was incontinent. So I knew that he had had a seizure. So we called 911 because the patient had no seizure history. And we sent the patient to the hospital, and they worked him up, and he had several EEGs. They could not precipitate another seizure. They couldn't provoke another seizure. So they said, oh, well, there's nothing wrong. The patient doesn't have a seizure disorder. We said, okay. So the patient came back to the clinic when he was released from the hospital. He came back a few weeks later, comes back, and the patient had another seizure. Well, as soon as we gave him local, and we called 911 again, and the same team, the same paramedics responded. And I was like, so do you think he has seizure disorder now? They're like, yeah, probably. We probably just didn't pick it up on the EEG. So eventually the patient did get diagnosed with epilepsy and got on some anti-epileptic drugs, and we were able to continue and finish his treatment. So I can tell you firsthand that it doesn't even have to be intravascular injection, that local anesthetic, you might induce a seizure, particularly in an older person. Nitrous oxide has never been shown to precipitate seizures. In fact, giving nitrous to people who have epilepsy may reduce the seizure risk. The patient might be more relaxed and less stressed. And so that's one idea. Lots of drugs interact with the anti-epileptics. So aspirin can increase the serum concentrations of valproate, Depakote, and Depakine. Fluconazole can increase plasma concentration of phenytoin, and clarithromycin does the same thing with Tegretol. So you have to be careful of your drug interactions. You should have an app for that, right? So you should either have LexiComp or some other app that helps you know which drugs are going to interact with other drugs, okay? You can't look them all up. There's way too many. You really do need artificial intelligence for that. You got to get an app. So let's see about managing seizures in the dental chair.
How are you doing today?
Hi, I'm doing good.
Okay, so we're just going to go over your health history. So, it says on here that you're epileptic.
Yes, I am.
So you have seizures frequently?
Yes, I get them often.
Often?
Yeah, the last one I had was like 2 months ago.
Like 2 months ago,
Yeah.
okay. And then, how long do they usually last?
They're about a minute.
A minute?
Yeah.
Do they ever go over a minute?
No,
No?
I've never had.
Always under a minute?
Yeah.
Okay. And, is there anything specific that brings it on your aura? Do you have any license?
Well, there's nothing specific. I feel like it's just like random. But for the aura, I usually get this like weird burnt rubber smell.
Burnt rubber?
Yeah.
Okay. And then, do you take any medications?
Yes, I'm taking Carbitrol for it.
Carbitrol.
Yeah.
Okay. Let me write that down. Okay. So everything looks good. So we're gonna start your treatment.
Okay.
Lean you back. Are you okay?
No, I'm not feeling too well. I can smell that burning rubber.
Okay. Alert. 1, 2, 3. What's happening here? She just started seizing about 5 seconds ago. Okay.
Here's the oxygen and medical emergency kit. I'll alert the front office.
So, Chief, are you okay? Well, you just had a seizure, okay?
Okay.
Everything's gonna be
blood
okay.
pressure.
It's gonna be okay. Is there anyone we can call?
Yeah, you can call my mom.
Okay, I'll call. Everything's gonna be okay. I'm scheduled for another day, alright?
Okay. Sounds good.
And actually, I think I looked at a lot of videos and I thought this one was pretty good. So some of the great things that they did here is they asked a lot of good questions, right? And again, we asked about the aura and the patient was able to tell us, and they kept the patient safe, right? They moved everything out of the way and they kept the patient safe, and they held her, but they didn't restrain her. They just made sure she didn't fall off the chair. They spoke gently to the patient when she gained consciousness. You can administer oxygen. That is recommended if you're, in your dental practice and you have your oxygen, right? And you should have that right there. The AED, I think is interesting that they get that because, the patient's not really at a risk for having a heart attack. Most patients will have that's not really the issue here, but okay, it's not wrong to have it. She asked, can we get somebody? And of course, they would have had emergency contact on file, so they're going to call her mom. And again, talking about one of the things I didn't see here is they didn't time the seizure. So what they should have done was started timing the seizure. But like in any medical emergency, I do love that the student doctor pointed to people and told them what they should do, right? So they have a system like we do at school where we have 1, 2, and 3, who's primary, who's secondary, who's tertiary in the medical response team. The primary member always stays with the patient. So you never leave the patient. You get number 2 or number 3 to get you what you need. So again, clearing the instruments from the patient, lowering the dental chair. If you can put the patient on their side, you should. You don't restrain them, but you want to protect them from hurting themselves. You want to time the seizure. And again, if we see a patient that lasts, and here it says 3 minutes, but most people will say 5 minutes. And if the patient obviously becomes cyanotic, if the patient starts to turn blue, then you definitely have something else going on and you need to get 911 fast. So when the seizure is over, and you saw this here, no further dental treatment for that day. Talk to the patient and evaluate their consciousness. You obviously don't let them leave the office until they are completely, fully aware. If the patient's alone, contact a family member or someone to give them a ride. The patient should not drive after the seizure, obviously. You should look inside the patient's mouth and determine that they didn't bite themselves. Patients will often bite their tongue and bite their cheeks. So just to make sure that nothing has happened there. And depending on how the person is put when they're post-ictal. So post-ictal means right after the seizure. So is the patient awake and alert? Do they know what's going on? You should always let the person go home with a responsible other adult, right? You shouldn't just let a person who's just had a seizure go home or drive home or get on the bus. Or they might need to go to the emergency room for further assessment. So an example of that might be someone who after the seizure never really gains full consciousness and seems very confused and doesn't really quite know what's going on. That's definitely a medical emergency because, patients naturally come out of their seizure state. So let's talk about gingival overgrowth. And this is a brand new study from last year. And it confirmed the hypothesis that there's a direct action of these drugs at the periodontal level. And we do know, besides it being a direct action, we know that it increases intracellular and extracellular matrix production. And there's a reduction in the degradation of those products. And then you get the gingival hyperplasia. Now, not everyone who gets the drugs will get the gingival hyperplasia. You actually have to have the gene for gingival hyperplasia, that when we give you the drug, this happens. And that explains why not everyone who gets the drug, that only 25 to 50% that people that get the drug actually will get gingival hyperplasia. So we know how it works now. Here was a good study. This is actually from 2021, management of medication-induced gingival hyperplasia, and looking at the systematic review. And this was including not only anti-seizure meds, but calcium channel blockers and immunosuppressive medications. We're just going to talk about the findings for the anti-seizure meds. So with the medication-induced gingival hyperplasia, there were multiple factors: age, the amount of inflammation you had to begin it, and the patient compliance. Different classes of medication might pose a higher risk of recurrence. The frequent use of adjunctive therapy, so using mouth rinses, also reduce the risk of recurrence. And there was a faster resolution of the gingival hyperplasia and less risk of recurrence when people used antiseptic mouth rinses. So interesting sort of large meta-analysis of the literature. Non-surgical therapies they looked at. And when they looked at non-surgical therapies, first of all, you can see this in 1 to 3 months. So patients can be on the drug for a pretty short time before you actually see gingival hyperplasia. The first line of treatment when it's mild or moderate is pretty conservative. It's pretty, and it's less expensive than having surgery for it. Plaque control, antimicrobial rinses, SRP. Obviously, faulty restorations or badly, constructed prosthesis need to be fixed. Enforcing good oral hygiene, and then regular periodontal maintenance. So kind of standard treatment for patients with general perio disease. But, you really have to make sure that these patients are keeping clean. Medication substitution. So with patients who are refractory and they don't do well with just sort of that phase 1 therapy, we move on to discussing with our neurology colleagues, like, let's change the medication. Can we get the patient on a new medication that will control the seizures just as well, or whatever else you're trying to control? Here, we're talking about seizures, and also improve the symptoms. So many times we'll talk with the neurologist and we'll say, listen, can you change the drug? Can we get them off this drug and on another anti-epileptic so we can improve the symptoms and the clinical presentation? We often see the resolution of the gingival hyperplasia as soon as we take the patient off the drug. Sometimes you actually do have to take the patient off the drug, and you will have to have some surgical intervention and remove all that gingiva, but it won't come back as long as the patient isn't put back on the drug. So it's really the most effective treatment is to get the patient off the drug that's causing the gingival hyperplasia. So when looking at surgical interventions in this study, they looked at conventional scalpel versus laser assisted versus electrosurgery. If anybody still has an electrosurge, we still have one in the clinic because some of our older practitioners really have not gotten on the laser train. They still like an electrosurge. The advantages of doing the surgery is if the patient fails on the conservative therapy, you're going to have to pretty much do it. And it's immediate resolution, right? As soon as you take a scalpel to that, the patient's better. We're not waiting a long time to look better. Instantly aesthetic, right? So the patient's kind of bummed out about having this, and we take a scalpel to them and they get better. And then it also expedites the resolution. So even if you're changing the drug, you want to probably do the surgery, and that will really expedite the entire process. When they looked at lasers, the CO2 laser has the least risk for relapse. Of course, they're very expensive and not everybody has one. The diode lasers work just as well. And the long-term clinical differences in the treatment outcomes weren't really significant. A couple of things in our treatment planning. So we're talking about treatment planning somebody, and we got all that great information. We're going to use the information we got in the medical history to determine what is the right kind of prosthesis for a person. Because if a person has an aura and says, look, I have a seizure every 2 months, like the young lady in the video, but I have an aura and I can usually get to a safe place, I'm less concerned about giving that patient a removable prosthesis. By the way, unless they have a Nesbitt denture, which I don't believe anyone is making these days, right? Any kind of removable partial, the patient isn't going to swallow. You can't swallow a partial. It's just too big, okay? You can't swallow a valplast, okay? You could crack it during a seizure, but I will tell you that I see lots and lots of patients with seizures, and I've seen patients break teeth off of their dentures, but I've never seen a patient like crack a denture in half. I have seen patients, crack an interim. They might crack their interim and get a piece of the acrylic lodged in their gums. And then of course we have to go and that's a real emergency, right? Because that's trauma. And then we have to deal with that. Certainly I wouldn't do like a PD partial in a kid with epilepsy because, that would be pretty dangerous. They're pretty thin and small. But anything else that you're going to do, you have to consider that when we do, if the patient's got a lot of trauma, if the patient's falling a lot, as a result of their seizures, we're really going to have to consider how are we going to protect their anteriors. So we do have patients, and these are patients with intellectual disabilities, and these are patients who have have, CP and seizures, NID. We do have some patients where we actually have them wearing like mouth guards with clasps on them all the time, because they're patients who don't always stay in their wheelchairs and they want to get up and ambulate, and then they have a seizure and then they fall. And so that's a problem. So in thinking about, can we restore the patient, it's really important to have a good seizure history. Most patients are not going to be like Katie that we saw, who are completely refractory, and she's not taking meds because she doesn't like the way they are. And when they loaded her with the meds, she had a horrible outcome in being in a wheelchair. So she is somebody that they might consider doing a VNS, or that's a patient who might consider other kinds of surgery, because it really, although she's amazing and really, so positive, it's really disruptive. Imagine if you had a job where you're seizing and you're falling down, and how would you get things done? So most people wouldn't choose to live like that. Most people would have the surgery or would be back on some sort of meds, trying to see if they could stop that kind of seizure activity. Because, you always have to be around someone, and she's running and she's probably running in places where, that are familiar. And if she has a seizure, she knows it's not going to be a long one. She can get up. But imagine what would happen if she went into status epilepticus and she's alone. So, you have to think about this long and hard. It's part of that treatment planning process. What is right for my patient, given that they have these seizures? And what's right for a patient who has one seizure a year is not right for a patient who'd say, like Katie, who's having 15 a day. Most patients that we see may have like one a day or two a day. We do have a young lady who does have full dentures. She's about 40, and she has several seizures a day, and she doesn't want to have a VNS, and she is already on 2 anti-epileptics. She has a little bit of an intellectual disability, but she does use a wheelchair. And so she straps herself in the wheelchair, and she lives with her mom. So someone's always around. And she's had full dentures now for about 12 years. And she hasn't had any instances where she bit herself or had any oral trauma with her dentures. So just having epilepsy is not a contraindication for having removable prostheses. So that's the point of that. And let's just see a little bit of what we don't want to say.
Are you drunk?
You're not disabled.
So, should I turn those lights off? Because I don't want you to go and have a seizure on me.
Should I hold you down when it happens?
Keep your hands off me.
Don't have a fit.
What can I choose?
Strangely enough, I don't control them.
I think people say it as like a joke as well. Like, don't have a fit.
I don't even like the word fit.
I think seizure's a better word.
Yeah,
it's more softer.
Seizure's it's a bit serious, that word.
It's an expression, like having a hissy fit or whatever.
It fits. That was a dad joke.
Are you possessed?
Are you?
My parents would always joke we should hold an exorcism because the priest isn't up to much at our local church.
He said to me, I don't pray enough. It's happening because I don't pray enough.
My mum used to say that to me. And people think that you've got some sort of evil spirit in you.
It's easier to say he's possessed rather than he needs help.
No, if I'm possessed by anything, it's not the epilepsy. It's crippling self-doubt.
Have you ever had a seizure during sex?
Yeah.
So you guys can watch the rest of it if you like. It is on YouTube. It's a YouTube video, what not to say to someone with epilepsy. And, I'm always on that we should be politically correct with our patients with any kind of disability. So I just put that little funny video in at the end to remind you that we don't say silly things to your patients. And that's what I have. So I will take any questions in the short time we have remaining.
Awesome. Thank you for great content as always. The first question is, can you use CVITRON on patients with VNS?
Oh, I'm so glad. I didn't put that in there because I wanted someone to ask the question. Yes, you can use a CVITRON with someone with VNS. Okay. What you don't want to do with someone who has a VNS is use them as the ground. So you don't want to actually use an electrosurge where you're using the patient as a ground. Apex locators have a even though you're using the patient as the ground in an apex locator, they have such a small charge. They don't really, you can use an apex, locator, and a CVITRON, but do not use an electrosurge.
We had a question asking where you're finding all these videos. Is there a specific source that has general and dental related videos for patients with complex medical and behavioral conditions?
Oh, I am a YouTube troller. I mean, I spend a lot of hours looking it up. Some of the videos, great, like the Epilepsy Foundation has some great videos. I'll always look and see what's available. And lots of people with disabilities have their own YouTube channels. And, I just look around and see what's available and then find ones that I like. The internet's amazing.
Have you ever had experience administering, oh geez, I'm going to butcher this word, benzodiazepine?
When benzos for when patients have a seizure?
Yes.
Yeah. So the only time that ever happens in our clinic is when patients are already sedated. So most of the drugs we use for IV sedation stop seizures. So most of them are actually antiepileptics. But for many of our patients who have seizures, regardless of the antiepileptics, when they wake up from their from the anesthetic, they might have a seizure. So then the anesthesiologist will give that to the patient if they do have a seizure, and it's if it doesn't stop right away. It's pretty rare. That's really an emergency drug for patients who have status epilepticus. And again, I wouldn't be trying to, God bless you if you can get a line in on somebody who's having a seizure. So if somebody's in status epilepticus, that's why we time it. You just need to call 911. And when the paramedics get there, they will administer, the drug. Your job is to keep the patient safe and turn them on their side and keep them breathing and keep their airway open.
If you are treating a uncooperative patient with protective stabilization on while using sedation and suddenly the patient develops a seizure, would you remove that device or would you leave it on to protect them from potentially?
Yeah, it's really tight. We use them occasionally. I would open it up and I would protect the patient, with my hands. I wouldn't leave the patient in the protective stabilization. I'd let them seize on their own.
Do patients with epilepsy and seizures usually have good teeth, or are they edentulous?
I don't know. Does anybody usually have good teeth, or are they edentulous? It's sort of like they're not different from other people. They just have epilepsy. So I would say, it depends. It just depends. We would never take teeth out on someone just because they have epilepsy.
Let's see. Should local anesthetic without epi ever be considered?
The epi doesn't seem to be the reason that the patient, the infiltration, that doesn't really necessarily seem to be the reason. And there really are no guidelines that say you shouldn't use it in patients who have epilepsy. What you should do is always aspirate like you do in every other patient when you're given a block.
I have a new patient who tends to have seizures during his sleep once a month and recently fractured his number 8 crown. Are occlusal guards an option?
Yes. And you might consider, if he has occlusal, if you give him an occlusal guard, I'd give him one that fits really well. And you might actually consider one that has clasps so that it doesn't dislodge when he has a seizure at night.
Are braces contraindicated on patients with multiple seizures a day?
So the question there is, what kind of braces are you using? So if you're using, if the patient, I guess it depends what kind of seizure they're having, number one. And number two, it really depends, if you're using traditional braces and they're on the buccal surfaces, you might, that might be a contraindication if the patient has a history of falling and having, oral trauma. We have many patients that we have braces on, and we'll try it. And then, if they have an episode, they have a seizure, and it seems like this is not going to work, we can always take them off. But I wouldn't say it's an absolute contraindication at all.
Is it a good idea to use a bite block when performing any treatment?
Yeah, I mean, it doesn't matter. if the patient has a seizure, you're going to take everything out of their mouth anyway. I like to use bite blocks with my patients just in general, because I find it easier to do dentistry, but there isn't really a reason to use one in a patient who has seizures, say, versus a patient who doesn't have seizures. Because if the patient starts to seize, you're going to take everything out of their mouth as fast as you can.
I have patients who have no history of seizures for the past 2 to 3 years. Can they get seizures during treatment? So that's question number one.
Yeah, they can. They can. Yeah, they could have a seizure.
Question number two, do we need medical clearance for such patients? Or are there any limitations on types of anesthetics or the number of anesthetics?
There really isn't. It's really just has to do with, the patient's history. There isn't like a limit to the number, different from the limit to other people based on, weight. But for patients who have epilepsy, they can always have a seizure. You should always be prepared that they might have another seizure.
We have an attendee here that says, I have seizures and my seizures are partial seizures. So I get the crazy questions like the end, and I work in dentistry. Mine are like a roller coaster ride and on meds, and man, do the meds make people tired.
Thank you for sharing. Thank you for sharing with us. And I appreciate that, because people really don't understand the struggles that people have, and you should share more often with your dental colleagues.
What kind of seizure patients are riskier to treat in a dental office? Maybe I'm misunderstanding that question.
Oh, like whether they have absent seizure or they have tonic clonic. So absent seizure, you saw the young lady, she just sort of spaces out and comes back. So she's not going to flail around and be at risk for biting herself or hurting herself on dental equipment. So patients who have tonic clonic seizures are obviously can be in a more dangerous situation. But again, you should be prepared and you should have a good history so that you know what to do if it happens.
Some dentists prefer to use gold for crowns on people with seizures, even on the front teeth. Are the zirconia or bruxer better?
I wouldn't use gold on the anteriors unless a patient really wanted it. I think if you're using zirconia, is pretty darn sturdy, and patients they still might break it. So I think you have to give patients, you have to tell patients, look, there's always a possibility that if you have a seizure, you might break it. But you know what? Anybody might fall and break their front tooth, and then you'd have to replace the crown anyway. So you have to really know how often does the patient have the seizures, and do they have an aura? Can they get to a safe place? So, the treatment planning is pretty important, but I wouldn't put gold crown on somebody just because they had seizures unless they wanted a gold crown on their front teeth.
How often should we see a patient that has been taking medication for seizures but has never had or never has an SRP?
Oh, so if the patient doesn't have gingival hyperplasia, they're not gonna get it because it's genetic. So either you have the gene where we give you the drug and you get gingival hyperplasia, or you don't. So if they don't have a history of gingival hyperplasia, you can see them like every other patient. If they've had a history of medication-induced gingival hyperplasia and they've had treatment, they're going to need to be followed up every 3 months. They're going to need SRPs. They're going to need chlorhexidine or other rinses.
How do you clasp a night guard?
Oh, how do you clasp a night guard? So yeah, so a lot of times we use like ball clasps on them for our patients with developmental disabilities on the molars. We'll put some, Adam's clasp, some little ball clasps on them so that they are, and that'll be embedded when the lab makes the night guard. So you have to have it made by the lab.
We've got a follow-up here to an earlier question. So do you think seizures are related to bruxism? That's why I asked if you have noticed most of your epileptic patients have a lot of teeth or mostly no teeth.
Oh, no, it's never, it hasn't, I've never seen, it's not reported. It's not necessarily, it's related with patients who have seizures and other things, like patients who have seizures and might have autism or an intellectual disability. Those patients tend to brux more. Patients with CP might clamp down and grind more. So patients who just have epilepsy, no, it hasn't been reported that they brux any more than other patients who, brux.
Are there any long-term, well, we've never seen this word before, sequelae? Is that how you pronounce it?
Yeah.
So, yeah. Are there any long-term sequelae for epilepsy that we should be aware of as dental providers?
Yeah. So, patients who have epilepsy, if they're gone into status epilepticus, there are some studies that show that patients can actually suffer from some sorts of brain damage if the seizure goes on for a very long time. Okay, so in patients that seize more than 5 minutes and they need to be hospitalized and they need emergency drugs and they're having trouble breaking that seizure, those patients can have problems. If they get anoxic, obviously the patient can have brain damage from the anoxia.
Great. Well, I think that's all the questions we have for tonight. As a reminder, if you did elect to receive CE credit for today's webinar, it is required that you complete the survey upon exiting the webinar. I would like to thank Dr. Perry for sharing her time with us today and presenting. And of course, thank you to everyone for attending. If you have any questions regarding CE or anything covered in this webinar series, such as if you want to watch parts 1, 2, or 3 again, or you missed them, please feel free to email us at webinars@henryschein.com. I would like to thank you all for joining us tonight, and hopefully we'll see you back here for part 5 in about 1 month.